to tonight's session on non-small cell lung cancer voices, addressing barriers to optimal health care in underserved communities. We appreciate you taking time to be here today. Please keep in mind that today's session is simply information only. Please consult your personal medical staff for any medical related questions or decisions. We ask that you please be respectful of everyone's lived experiences and to please stay muted unless you're speaking. There are closed captions available as well if you would like to turn those on. And so we'd love to hear from you in the chat where you're tuning in from tonight. And then we'll go ahead and get started with our moderator this evening, Dave Bjork.
And hello, everybody. My name is Dave Bjork, and I am a lung cancer survivor and a patient advocate. And it is Lung Cancer Awareness Month, so I want to acknowledge that to all our friends and the affected by lung cancer in the community. I'm honored to be the moderator of tonight's session. I want to just give you a quick overview of how this came to be. And I worked with my friend Lisa Cruz at Takeda, who is also passionate about health equity and supporting the lung cancer community. And we got together because we wanted to address some of the barriers to getting optimal care in the non-small cell lung cancer community, and particularly in underserved communities. So we put together an amazing panel. We call it our advisory or roundtable, and we had voices of very, very diverse lived experience, which is very important to me. So it's racially and ethnically and geographically, and we wanted to talk about what are some of the barriers, what have people experienced in their communities. And we did, through that process of working with our amazing roundtable of advisors, we really focused on what we heard. And what we heard was communication and navigation, biomarker testing, and stigma as some of the things that really stood out to us as barriers in the non-small cell lung cancer community. And so we're going to continue this work together, and we really do want to have an impact on improving optimal care for everybody. And it's something that I'm extremely passionate about, and I know Lisa's very passionate about, and you'll hear from the people that we have gathered here tonight, and they're equally as passionate about it, but they're going to share their lived experience, and that's what's really important to us. And so we have four wonderful people that have been part of this process of gathering together with us to share their experiences tonight with us. And I'm truly honored. Thank you all so much for coming together with us tonight, and thank you all who are attending. And so I'd like to really, start by introducing these beautiful people that I have here with us tonight to share their experiences. So I'd like to have each of you give a very brief introduction, maybe 45. Oh, I'm sorry. I have to introduce my friend Lisa Cruz first. I apologize. Sorry, Lisa. That was no slight. So I'm going to hand it over to Lisa to give her opening remarks on the work that we're doing together. So Lisa.
Thanks, Stevie. I don't take it as a slight. Don't worry. No, but thank you. I think you did such a great job introducing the work we've been doing together. So my name's Lisa Cruz, and I work at Takeda Oncology, and I lead our non-small cell lung cancer patient advocacy work. I came to Takeda shortly after my father lost his battle with lung cancer to really kind of move the field forward. There were so many experiences that I had as his caregiver and advocate during his journey that I just really felt passionate that I wanted to contribute to this advocacy community in a positive way and really help people as they are navigating their journey throughout the early, middle, and later parts of that journey. I've had the honor of working with DB and this panel for over a year in Gryt Health, and it's been a really great partnership to get to where we are today, to bring like Dave said, the 4 individuals on the panel this evening to talk about their lived experiences within the healthcare ecosystem, and what some of the challenges that they've had while kind of participating in this community, and then also like to discuss some of the successes as well. So this project has been so meaningful for me, and I'm just really looking forward to the conversation tonight. But as DB knows, like our conversation won't end here. We have so much more work to do, and I look forward to kind of moving this forward. So with that, I'll pass it back over to DB.
Thank you, Lisa. I'm really honored to be working with you as well. So now I have the privilege of introducing our amazing roundtable for tonight's panel for tonight's session. And if each of you could just maybe just a minute or so, we'll be talking later, but just in a minute, just briefly introduce yourselves. And I'd like to start with you, Laronica.
Hey everybody, my name is Laronica Conway, and I currently live in Birmingham, Alabama. I'm originally from Louisiana, which is where my mom lived when she was diagnosed in 2008 with non-small cell lung cancer. I spent every weekend driving back and forth as a caregiver from Alabama to Louisiana, 10 hours round trip. It did not feel like a chore back then. It didn't feel like it was a burden. I felt like for me, it was my duty and my job to sort of provide comfort for her. I would do it all over again. So I want people to understand that there is hope. And so that's how I felt driving back and forth. You know, I never felt tired. You know, of course, at some point I probably did, but running off adrenaline, you know. And at this point, I actually work in healthcare now. I'm kind of like Lisa. I ended up sort of changing my career path because I saw that things needed to change, and I wanted to do just a little bit on my end to make those changes. I had no idea what that looked like, but becoming I guess a lung cancer advocate or maybe a healthcare advocate, just being a part of these discussions makes me feel like I'm doing something and that my mom didn't die in vain. So I'm glad to be here. Thank you.
Thank you, Laronica. And now I'd like to turn it to my fellow Boston area friend, Barry. Barry, why don't you introduce yourself, please?
Hello to everyone. My name is Barry Nelson. I live in Boston, Massachusetts. I'm a lung cancer survivor. I'm also a volunteer at Brigham and Women's Hospital in the Center for Patients and Families. I sit on a number of the patient family advisory councils. I have participated in PCORI research initiatives, and I'm very much involved in helping to reach out to communities to let them know about the importance of research, medicine, and, you know, from a spiritual aspect, of also how important faith is on this journey, and help us to stay focused on, you know, opportunities to improve our health and those people who are coming behind us. I come from a family where my mother, her children, my mother and her sisters, they all died from cancer, various different types of cancer, pancreatic cancer, breast cancer. But so cancer is nothing new to me. But it is an opportunity for me, because my family has experienced so much, is to give something back. And so that's why I become an advocate, and I am honored to be here tonight to share my story with each and every one of you.
Great. Thank you very much, Barry.
You're welcome.
Now I'd like to turn to my friend, Michelle, to introduce yourself, please.
My name is Michelle. I am a nurse navigator. I started off my career as an exercise physiologist in cardiac rehab and decided to change my career to become a nurse when I found out that people who were diagnosed with cancer didn't have the same access to resources. And so, and as a nurse, I got the opportunity to work with working with early detection. And for the past 10 years, I've been developing lung cancer screening and incidental nodule program, where my passion is is in helping to ensure that every person receives the highest level of care throughout the diagnosis process, and making sure that they receive care in a timely manner and that they're not alone. And so my passion is to make sure that people don't fall through the cracks, and to serve them.
Awesome. Thank you so much, Michelle. And finally, Dr. Danny Nguyen, if you would please introduce yourself. Great to see you.
My name is Danny Nguyen. Sorry about my voice. I'm getting over a cold. I'm a medical oncologist working over at City Hope in Orange County in California. This work became important to me as I was trying to increase access to lung cancer clinical trials by trying to bring more of them into the community setting, as opposed to keeping them in the academic setting. So I'm happy to be here, and working with Dave and his group.
Awesome. Thank you all. It's really great to see you all again. And thanks for those introductions. I'd like to start our discussion tonight. A lot of our conversations over the past year have focused on empathy. And we heard from you and the other advisors that, a more empathetic healthcare system would lead to better patient outcomes. And I certainly agree with that. So I'd like to start by asking Barry and Michelle. Barry, how has the role of empathy, or the lack thereof, shaped your experience with the healthcare system?
If I shared with my opening introduction that, I come from a family that, has a background with cancer. When I was diagnosed with cancer, I went to an institution where, I was able to get my diagnosis in a relatively short period of time, within 1 week after going to the doctor. That after the providers had worked out a treatment plan, and I started the process of, radiation and chemotherapy, there was some ambiguity around what my prognosis would be when I would go for my treatment. And I kept communicating to my providers that I needed to get them all in the same room so we could have a discussion. And so it took a bit of time. I kept getting this pushback. And so the long and the short of it is that we ended up having this meeting. But what happened at the meeting, my other clinicians and research team, they were there. I had a primary oncologist, a radiation oncologist, and a chemo oncologist. Everyone was there except for the primary oncologist. He came to the room late. He walked in the room, there were people sitting around, we were in a conference room, people sitting around the table. He walks in the room, the first thing he says is, "This is a waste of our time. You're gonna die, and you need to accept it." And so, of course, everyone in the room, they gasped for air. I remember my oldest daughter was with me. She looked at me like, "Are you okay?" So I thanked everyone, and I went home and I called my primary care, and I explained to him I could never go back there again. I only wanted to see a lung cancer specialist. Now, as I'm talking to my primary care on the phone, explaining this to him, he's saying, "Okay, I'm looking at your file. I remember that you had got a second opinion. So can I send you back to that oncologist who gave you the second opinion?" And I said, "Yes, I would be happy to see that. He's a lung cancer specialist." The appointment was made. I went to see that oncologist. The first thing I shared with him what my experience was. The first thing he did was apologize, which he didn't need to do. I mean, that wasn't his institution, but he apologized. And he said, "Mr. Nelson, we're going to fight for you as hard as you are fighting." And so to me, that's what all patients are looking for. They're looking for encouragement. They're looking for partnership. They're looking for an opportunity to build trust with someone, because most people, they don't really know what this means. What does this diagnosis really mean when it comes to their everyday life? They have an understanding, they've seen the impact of other people in their lives, but personally experiencing it is a whole nother situation. So to me, how a situation started off very negatively, it turned out to be very positive for me.
Thank you so much, Barry. Yeah, and every time I hear your story, you see me shaking my head, because it's really hard for me to believe that you were treated that way, but I'm glad that you ended up in a good situation. Michelle, I know you and I've talked many times about empathy, and I love how you talk about it. I'd love to have you talk about the role of empathy, or the lack thereof, and how it's shaped your experience. So Michelle.
I feel like it's healthcare professionals. I mean, we are actually the biggest barrier, because when a person comes into our clinic, we see a patient. We don't see them as an equal member of the medical team, you know, and they are the expert in the person. The medical team is the expert in the medicine and the science and the treatment. And so we tend to not listen to what the people are trying to tell us. And so we were prone to like bias and not, and so, and from a personal impact, I was able to see this when a family member was diagnosed with lung cancer, and the medical team told a family member that we don't include the patient in the treatment decisions. And this was in the 2020s. And I'm like, no, there's a shared decision making. And so that woke me up and helped me realize I need to be there and be more aware of my actions on how I communicate to patients or people diagnosed, because it's not what we say, it's how we say it. So that's what I take it.
Yeah, and I thank you so much, Michelle. And I also believe in the powerful role that a nurse navigator can play, you know, in bringing that empathy to the patient experience. So, you know, thank you for what you do and taking the approach that you do. I'm sure all of us would agree that we really appreciate the work that you do. I'd now like to talk about a topic that's very close to my heart, and it's biomarker testing. And people who know me know I'm not a scientist, but I have read as much as I possibly can about biomarker testing and how, when we talk about hope, Veronica and others have mentioned the word hope tonight, that I was diagnosed many years ago and there was not a lot of hope in lung cancer, but now there is, because there are targeted treatments for many forms of non-small cell lung cancer. I'd like to start with you, Danny. You know, with precision medicine being on the forefront of cancer care, how do you share and discuss biomarker testing with your patients and loved ones? And maybe kind of tell us what has worked or what has maybe been challenging for you and your team.
Unfortunately, a lot of patients and families are becoming a lot more educated by themselves, you know, a lot of information at their fingertips on the internet and Google. But to the patients and families that don't know about biomarker testing, I like to say that it's kind of like a way to characterize the mutations that are contributing to the growth of that cancer. And as you mentioned, this is important because we have more treatment options now that can potentially target these mutations. And specifically, many of these treatments just have like a better side effect profile than traditional chemotherapy, in addition to being, you know, sometimes way more effective as well. When patients hear about this, they're usually very enthusiastic about testing. And I find like just going through the diagrams of like the mutations that are possible for lung cancer and walking through the NCCN guidelines about, I think there's like 10 different mutations right now in the NCCN guidelines for lung cancer regarding the mutations that you can act on. So, you know, I feel like just going through, not only just talking with them, but going through imaging and diagrams, flow charts kind of helps make that information more easily understandable. And, you know, some barriers initially used to be just like the turnaround time. It wouldn't be uncommon to get results 3 or 4 weeks later. And, you know, by that time, you probably didn't need to start on chemo and then switch later. And then at that, back then, getting insurance authorization used to be kind of tricky. But fortunately, biomarker testing is standard care, not only for most non-small cell lung cancers, but many other different types of cancers too. You know, I think I want patients and families to understand that insurance has been kind of like an issue for me as a provider a lot of times, but the actual biomarker testing company, there's a lot of resources out there to help with patients. They usually, many of them have caps on how much money that they collect. And, you know, some patients don't even pay anything at all. So I don't want insurance or money to impact access to biomarker testing.
Yeah, I totally agree with that. And I know you've also done work in your team and trying to address the language barrier too, and with your community as well. I'd like you just to briefly mention that if you don't mind.
Yeah, fortunately, I mean, down in Southern California in Orange County, I'm Vietnamese, and I do service a large part of the Vietnamese population, and a lot of my staff are Vietnamese speaking. And I think that, and actually a lot of the staff all throughout the patient's journey, including the front desk, the nursing staff, me, the patient is able to communicate in a way that they feel comfortable with. And also they're getting information that they can easily understand. Even using medical interpretation services. I've used them actually to translate Vietnamese before. And sometimes it's not a one-to-one translation. And some things can get missed, unfortunately. So, I think getting the information in a patient who has where English is not the first primary language, I think helps convey the information as well.
Awesome. That's so important. And we're going to continue working on these types of things going forward into next year. So I'm really looking forward to that. Veronica, I'd like to have you tell us about your mom's experience with biomarker testing and how did that affect her treatment, both physically and emotionally?
It's great to hear how things have changed in the last few years, because when mom was diagnosed in 2008, this was not a normal conversation. No one was just sitting around talking about biomarker testing and mutations. I think back then, was it Keytruda or Xalkori? I can't remember which one was the first one they were really talking about. And that actually wasn't the actual name. There was I guess the name that they had not come up with yet. But my mom, we had an appointment here at UAB, as a matter of fact, and it was sort of like a last ditch effort. We didn't know it was a last ditch effort at the time, but it was just one thing that we wanted to try and said, hey, let's go see some specialists at UAB. And we get here and great doctor. We started talking about some options, and you could tell, and looking back, I could tell that he wanted to give us some hope. And he said, hey, there may be some clinical trials that you might qualify for. Would you be interested? And of course, my mom's like, yeah, sure. What do I need to do? And of course, at that point, I'm thinking, yeah, okay, let's do this. Knowing that my mom was, a little weak. And I, at that point, had started reading up on, the length of time a person would have to be on a clinical trial to see some sort of difference. But if she was happy about trying something, I was happy about it. And he said, okay, what we need to do is go back to the facility that may have taken a biopsy and ask them to send us a piece of tissue. And this is the way he was explaining it, which was great. A piece of tissue where we could test it and see if she has a particular biomarker. And we were like, okay, great. So we go home to Louisiana and we're waiting, and we never heard back. Looking back, we don't know really what happened. We don't know if the request to the facility ever went through, or if the facility received the request and never followed up with the results, or it was somewhere in between. We never knew. So, I don't know if we weren't even supposed to be a part of it. I think, though, it was having that hope and then being let down was the part that was the worst. Sometimes you wonder, should they even have brought it up? It's like, it's good to know about it, but if you can't do anything about it, do you really want to know? But I think now, looking at how things have advanced, absolutely people want to know. So I think the advancements are fantastic. So it's been great to see.
Yeah, and you really bring up the issue of communication and how important that is,
Right.
I know we've talked in our group in this roundtable, we talked a lot about that communication. So thank you very much for sharing that. I'd like to move on now to talking about second opinions and the patient voice. And I'd like to start with you, Danny. We all know that cancer diagnosis can be so overwhelming, emotionally draining experience for a patient and their care team, their caregivers, and ultimately they want to ensure that they're receiving the best care possible. So I know we've talked about second opinions. I'd love to have you tell us how you communicate to your patients and that they're allowed to and encouraged to get a second opinion. Because I love clinicians like you who do encourage that. So can you tell us a little bit more about how you approach that?
I've learned to incorporate offering second opinions as kind of like an additional treatment option, actually. Specifically, I think a lot of patients are worried if getting a second opinion will get authorized by their insurance, but then I write down, it's, to see if there's other clinical trial options or something like that, or second opinion. So, that's what I've started doing. And I learned that with cancer treatment constantly changing, new things are coming out in development, and I don't have access to everything, so I've recognized that. And I think, I think actually most patients are happy with their current oncologist. And, I think some patients may actually view asking for themselves for a second opinion as potentially offending their physician. And that's why I try to offer it myself to kind of like break that ice. And, I just telling them point blank that it doesn't offend me, and that I just want what's best for them. And it oftentimes just getting another opinion to either confirm the plan or maybe offer a different treatment option helps provide the patient with some peace of mind. And, and also I think from the patient side, sometimes patients feel that when I'm offering a second opinion that, their case may be like unusual or very serious and that I need like extra help. But no, again, it's just to reaffirm that, we want to make sure that we have all our options on the table. So I think, when you kind of like lay it out like that, I think most patients are okay with a second opinion. And actually, I'd say about half the time, the patients appreciate being offered, but still don't take me up on the offer. So, but I do like to make sure that, it's out there, and that's one barrier that they don't have to overcome to trying to request one.
Well, the fact that you encourage it, I think, is really an amazing way to build trust with your patients, and whether they take you up on it or not. I think if we continue on the theme of empathy and hope, just the fact that you're people like you, other clinicians like you, who are offering that and not feeling offended, because I do believe that a lot of people do think they're going to offend their doctor if I don't want to tell him that because, he's going to feel bad. And I'd also like to turn to you, Barry. Was accessing a second opinion an option for you? And if so, how did it affect the direction of your treatment?
So David, I had shared earlier in my story that, I may not have made it clear that initially I started at one institution. I was diagnosed. I would begin, had a treatment plan. I'd start the treatment plan. There was some confusion about, the long-term prognosis. So confusion was building for me, right? And so I asked to get a second opinion. And so the first, again, it goes back to that other oncologist who was the primary oncologist. He was like, well, we don't feel like you need one. And I was like, well, this is what I want. This is what I want. And he says, well, I don't think your insurance will approve that. So what I actually did was I called my primary care. And my primary care, he fought the fight to get me the second opinion. And that's something that I failed to state earlier in the beginning of my introduction, is my primary care played such an important role for me getting diagnosed quickly. Whenever I ran into any type of conflict or confusion, I would go to him. He would follow up, and he would, come back to me, and we would sit down and we would talk and communicate, and So I did get a second opinion, and I'm so happy that I did, because when I was really overwhelmed by the way I felt I was treated, immediately my primary care, he says, "You got a second opinion, just let me send you back there." And it was, to me, that was one of the greatest things I could have done, because when I was diagnosed with stage 3B. So basically they told me I had less than 6 months to live. So to me, I didn't have a lot of time to be sitting around trying to people decide what they want to do and what they don't want to do. We need to get busy and move forward if there is an opportunity to bring hope into my life. So that's how I saw it.
Yeah, and we're glad you got a second opinion too, Barry. and I think that point that you made is really an important one, where at first you were not offered, or you're almost discouraged from, or not taken seriously, or whatever. And you had the courage to speak up, to tell them what you wanted. And I love you sharing that, because I think other patients can gain inspiration and hope from that they can also do the same thing. So thank you for that. Veronica, I wanted to ask you the same question. If accessing a second opinion was an option for your mom, and if so, how did it affect the direction of the treatment?
This is where geography plays a major role. We talk a lot about being in a rural setting and being in a small town or small place without having access to big city hospitals. And so when my mom was diagnosed, she was diagnosed in a city where there's maybe 60,000 people, maybe. And so we're possibly 4.5 hours from Houston. So a lot of people that we knew had gone to MD Anderson. So it wasn't unheard of to go to MD Anderson. Now, of course, we had been told that whatever she was getting in the small town would be the same, but we wanted to go just to be sure. I mean, how would you know? You're kind of isolated. You're not seeing doctors who are, traveling all over the place. You're seeing small town doctors, and no knock against them, but their access isn't as broad as those who are in larger facilities. So for us, going to MD Anderson was easier, and it allowed her to move forward with her treatment, because she could kind of check the box. She could say, hey, I've done that. I feel better about it. They told her the exact same thing. This is the treatment that you would get. It's the same thing you're getting now. But feel free to come back, every 6 months if you just want to see us, that's fine. And so, yeah, it allowed us to take a deep breath. And we started with the treatment in the small town. But yeah, I think it allows you to sort of feel good about your decision.
That's a great insight, to the fact that it wasn't that you got a second opinion change, but you actually just had a chance to breathe and really feel more confident and being treated. Probably your mom probably appreciated being treated closer to home.
Right,
so
right.
that's
Absolutely.
really important. Yeah,
that was the main thing, being closer to home. Yeah,
definitely. Thank you. Michelle, again, my nurse navigator friend, for full disclosure, my wife is a nurse, so I have a special spot in my heart for nurses. When I'd like to ask you, for people who might not have access, or be at a facility where they don't have navigators, how can patients and their families advocate for themselves, or where can they find support?
There's always a social worker. There's a social worker in the cancer center. You can always approach for resources. But there's the nonprofits like Longevity and GoTo Foundation. They have the helpline where they can help you with everything from anything you need. They will help you and go out of your way. And they're all connected with all the hospitals, whether it's a second opinion or just biomarker testing, anything, or support with other survivors. They're always there. I always tell patients, always have an advocate with you. Could be a friend, a spouse, a family member, and don't be afraid to ask questions. There are no stupid questions, and keep a notebook and just and when you're in there, you're a member of your team, and just and just know that you're not alone. And so, but there's always someone to help. So American Cancer Society, go-to foundation longevity. So connect early if you can, as early as possible, and just stay in contact.
Definitely. Yeah, thank you so much for that. There are resources, but I think sometimes the challenge is getting the direction to find the resources that are available. So I think that's really good insight. So thank you so much, Michelle. I'd like to, as we kind of come to the end of our session, I'd like to ask each of you. We're talking about hope, and I think that's a real theme that I always get when I talk with you all. I'd like to ask each of you, and I'm going to start with you, Danny. Just if you can tell us one small step people or patients and families and or providers can take towards creating a more equitable future in healthcare.
You know, the problem of health inequality is just really big, multifaceted. But like in regards to what maybe patients and family can do, I think the biggest things is that they need to educate themselves. Cancer is complex. Lung cancer is complex. There's so many treatment options out there now. But get as much information as you can from reputable sources. In terms of information, this also includes biomarker testing and information there, because this really can influence the treatment that you get. And then, you know, just ask your provider if biomarker testing is appropriate for you. And, you know, there's actually a lot of biomarkers that don't actually have treatment options on the market now, but they're available in clinical trials. And, you know, clinical trials now are, you know, I think there's a stigma behind clinical trials as well, you know, where patients sometimes feel like a clinical trial is like a last ditch effort. You like ran out of options. So, you know, so, I mean, it's just biomarker testing is very important. And again, I don't want patients to have insurance and financial resources as a barrier. Just reach out to the biomarker testing company, and many of them have very robust patient assistant programs.
That's great. Thank you so much for sharing, Danny. I'm going to pass it to you, Barry, and maybe in a couple minutes you could answer the same question. Is the one thing people or providers can do towards creating a more equitable future in healthcare?
Well, I think it starts with the patient, especially for me, is being clear with the provider that, you know, I want to trust them. They are the subject matter expert. They have the expertise that I'm not familiar with. So I'm looking to them for guidance, and I want them to be my partner in this situation, not, you know, look at me as I'm just a patient, or as Michelle said, I'm just a number. Because, you know, part to me, from my experience, having that trust, let me say it a different way. Being in an institution where they didn't appreciate me, and being in an institution where I felt like they did everything they could, where the doctor told me, he said, we're going to use all the tools in the toolbox to help you. That encouraged me so much. And so it made me feel like, you know, someone was standing with me. I was not standing by myself. And they didn't promise me that I was going to live or I was going to get great outcomes. All they did was say, we're going to fight as hard as you did. And so what that did for me was make me feel like I was with people who understood my challenge, and that encouraged me. And I think that was an integral part of my recovery, you know, of my healing. And so I encourage other patients to just be honest with your providers and tell them, you know, listen, this is new to me. I'm not clear on this, and I need you to be honest and answer my questions. And I might have too many questions for you, but I'm not doing it to annoy you. I'm doing it because I'm trying to process this. I'm trying to see how I'm going to navigate this, not only for myself, but for my family or my caregiver, whoever it is, helping them on this journey. You know, so it's not singular. You know, it affects the family just as much as it affects a person who's going through this situation here.
Thank you so much. That's very good insight, Barry. Thank you so much for sharing your story. We just have a few minutes left, but I do want to get to Veronica, Michelle. Veronica, maybe you could answer the same question.
I'll just say this, just remember that patients and their families are always waiting on that phone call, whether it's good or bad, okay? And I'm on the other side now that I work in clinical trials. If a patient calls and they have a question, just call them back, even if you don't have an answer. They want to hear from you. They want to know that you care enough to call them back and to explain the process, even if the process is convoluted and takes, an hour to explain. They just need to hear the voice of the person that's going to help them. Even if you think, well, you know what, this is not going to help them, but they don't know that. You don't need to tell them that. Just hearing your voice gives them hope. And making those phone calls it's what's important to them. So it may seem small, but just returning phone calls and keeping in touch with those patients and the families, I think it goes a long way.
Definitely. Thank you so much for sharing. And I'm going to finish up here with you, Michelle, if you could tell us your thoughts on the same question.
As healthcare professionals, we need to better educate our healthcare staff on how to communicate with the people diagnosed, so we can communicate without judgment and being in their shoes. It's not what we say, it's how we say it. And we don't want people to feel like when they ask a question that we are inconvenienced, because we're here to serve the people. And so we just have to be aware of that people come with their own experiences, and we need to be aware of how we communicate.
Awesome. Thank you so much, Michelle. That's a great way for us to end it. And I really like the way you all have framed this conversation. We're so grateful for your sharing of your stories, your lived experience. And I'm looking forward to continuing to work with all of you and continue to this conversation. So thank you all so much for sharing your stories and for the advocacy work that you do and being a voice of hope for people. And so again, thank you so much.